Hi, I'm Megan, and today's presentation will be the EAD in-service standard procedure for placement of NG and NE tubes. There are different types of feeding tubes, including the nasogastric, nasoenteric, and gastrostomy tubes. Nasogastric or NG tubes are a type of catheter which is inserted through the nose into the stomach. These are typically used for short-term to deliver substances, nutrition substances, or even some medications, or to draw substances out. There are multiple types of NG tubes, including a single lumen or a double lumen. NG tubes can be used to provide enteral nutrition and medications, or even for suctioning stomach contents in the case of poisoning or overdosing. Conditions that may require the use of an NG tube include malnutrition, dysphagia, head and neck cancer, endotracheal intubation, and they're typically used for 4 to 6 week periods. Nasoenteric feeding tubes include the nasoduodenal or ND tube or the nasojunal or NJ tube. These are primarily used for nutrition purposes, and they're also inserted through the nose, or the nostrils, but instead of resting within the stomach like the NG tube, they rest within the small intestine. Gastrostomy tubes, or also called G tubes or PEG tubes, are placed directly into the stomach, while jejunostomy tubes are placed directly into the jejunum. Typically, these tubes are used for longer periods of time. These are some images of feeding tubes. On the left with the orange are examples of NG tubes, which, as you can see from the diagram below, they're inserted through the nostrils into the stomach. The middle picture shows different types of feeding tubes and where they rest, such as the NG tube, again, resting within the stomach, the ND tube resting within the duodenum, and the NJ tube resting within the jejunum. This picture also shows the gastrostomy tube, the G tube, and the jejunostomy tube, or the J tube. The gastrostomy tube is directly inserted into the stomach through the abdomen, and the jejunostomy tube is directly inserted into the jejunum portion of the small intestine. The diagram to the right also shows what the tube looks like once it's inserted into the stomach or intestine, and it can be anchored with a balloon or another clasping device. The indications and contraindications for tube feeding types. Indications for the NG and NE tubes can include injury to head and neck, cancers, eating disorders, illnesses that can cause swallowing issues, diseases such as Crohn or celiac, surgery or illness that affects swallowing, intubation, stroke, paralysis, neurological disorders, and other conditions that affect swallowing or absorption. Contraindications include bowel obstruction, obstruction of the ileus, vomiting or diarrhea, upper GI bleeding, high output fistulas, major gastrointestinal ischemia, or severe hemodynamic instability. Other contraindications can include coagulation abnormalities, esophageal abnormalities, recent esophageal intervention, maxillofacial trauma, or nasopharyngeal or oropharyngeal obstructions. Enteral access tube types, small and large bores. Small bore tubes are narrow types of feeding tubes inserted through the nose into the stomach, which allow medications and thin liquid formulas to be given to the patient. These tubes are thinner nasogastric tubes, and typically these are more comfortable for the patient. Large bore tubes can be necessary for administering medications and pureed foods in some cases. They typically clot less as compared to small bore feeding tubes, but they are not as comfortable for the patient due to their large diameter. Here are some examples of the access tube types. The Salem sump tube is typically known as a large bore feeding tube due to its larger diameter, and the bottom two, the Dobhoff tubes, are known as small bore feeding tubes, which you can see in comparison are smaller in diameter. The indications and contraindications for bore types. Small bore feeding tubes, they're generally more comfortable. They're compatible with thin liquid formulas and some medications, but there are limitations, such as they can possibly branch easier into the bronchial tubes due to their small nature. They can cause pulmonary injury if this occurs. They can also get clogged more easily or become dislodged within the digestive tract. Large bore feeding tubes are important and imperative for administering medications and administering pureed foods. However, they're generally more uncomfortable due to their diameter and size, and they're not indicated for patients with recent esophageal surgeries or with restricted airways. When placing a feeding tube, it's important to follow the protocols of the facility that you're in. One way to ensure that you're placing a feeding tube correctly is to use a checklist such as the Aspen Bedside Feeding Tube Placement Competency Checklist. This checklist is a general checklist for tube placement feedings. The steps in the summary include verifying the tube placement order, reviewing the patient health history for any contraindications to the feeding tube, obtaining verbal consent if applicable, gathering the appropriate supplies, performing hand hygiene, which should also be done upon entry to a patient room, introducing yourself to the patient and explaining the procedure, offering comfort, allowing the patient to ask any questions that they may have, confirming the patient's identity in various ways, so obtaining their name, their medical record number, their date of birth, and doing a verbal name check as well as checking their hospital ID wristband to ensure that you have the correct patient. You should place the patient in the appropriate position for the procedure, trying to make the patient as comfortable as possible. And then you should place a tube based on the protocol that you're using, in this case, the CORTRAC electromagnetic imaging system, which uses electromagnetic receivers to visualize the tube as it's being placed at bedside. Once the tube is placed and you have a visualization, you should secure the tube. There are various ways you can secure a feeding tube, in this case, a nasal brittle, as per the facility policy. You should educate the patient and family on what is going on during the process, if applicable, but also on care for the feeding tube and what to expect. Document as per hospital policy, and then you should verify the proper tube placement. The CORTRAC electromagnetic imaging system allows for tubes to be placed at the bedside, so you can visualize the tube as you're placing it. And it uses an electromagnetic sensing device and receivers to track the placement of the tube as it's being guided to the digestive system. This can help reduce the risk of the tube branching into the lungs and causing pulmonary injury. So, other standard procedures for tube placements can include the blind placement technique, direct visualization, and the real-time indirect visualization technique. The first step is always to select the appropriate device, the appropriate timing, amount, ensuring that you have the correct procedure and patient. The blind placement technique is a standard of practice in which the tube is inserted without any direct visualization tools. There are advancement protocols during this procedure known as the corkscrew or self-propelling with magnetic tubes. The direct visualization technique includes endoscopic or camera-directed guidance to visualize the GI tract during placement. And the real-time indirect visualization technique involves fluoroscopy, ultrasound, electromagnetic guidance, such as the CORTRAC. However, these are not considered direct visualization techniques. Tube placement verification is essential. There are different ways you can verify these. With the CORTRAC, you can use the receivers to track and make sure it is placed correctly, but other ways to check are pH, in which the feedings are not conducted for up to 30 minutes, and a small amount of gastric fluid is withdrawn to test for the gastric pH. If you're talking about an NG tube, you would look for a pH range of 1.5 to 5. Radiographic, which is considered the gold standard, which is x-rays of the lower chest and upper abdomen to confirm placement. Capnography, which is calorimetric CO2, carbon dioxide, which is a detector used during the placement. If the tube is misplaced, there will be a CO2 waveform or color change. A camera, you can use these for small bore feeding tubes. Ultrasound helps you view the upper GI tract, including the esophagus, epigastrium, gastric fundus, and the antrum to ensure proper placement. Or EMPD, which is a type of feeding tube, which is specialized transmitting style, where the receiver is placed on the patient's lower chest, upper abdomen, and it can be monitored during the placement. Again, this is the core track. Here are examples of tube securements. On the far right is the nasal brittle, which is used at this facility. So that, again, the nasal brittle is on the far right, and it is the blue securement. Other securements can be different types of tape and attachments, such as standard medical tape or the Tegaderm. Thank you.